So, very good afternoon, and thanks to Sudipta for putting this up and the whole organizing team. So, today my job is to speak on the genetic landscape of Indian patients with REP and CP. And it's an honor to speak on this topic in front of people like Dr. Whitcomb, Asamin, and Pramod Garg, who has done lots of seminal work in this area. So, genetics in pancreatitis has come a long way, right from the first paper on the PRSS by Dr. Whitcomb to the most recent TRPV6. So how these mutations work? So this is the normal physiology. Trypsin goes into the duodenum and enterokinase activates into active trypsin. But in patients where there is acinar mutations in the acinar gene, PRSS once a gain of function. SPINK1 CTRC is a loss of function. Cathepsin be something that we often find regularly in Indian patients. We really don't know the mechanism, but probably it could be related to missorting of lysosomal transport. And ER stress, of course, CPA1. And then trypsin can get activated within the duct if the bicarbonate system gets impaired because of mutation of CFTR and CASR. And then there is, of course, claudin and TRPV6. We just heard a great talk on that, that affects the ductal calcium channels. And based on these functions, these mutations can be classified into different functional pathway-dependent classification. We had already heard this. I'll skip the slide. So let's quickly take you through some of the key studies from India that talks about genetics. So this is an early study that was published in around 2006 from CCMB. Which look at the cathepsin B polymorphisms. So there were two cohorts, and this specific gene, the L26V, came out prominently in both the original and replication cohort, and we do find in our cases often. Some of this has not been replicated in the West, and there is always a controversy if this gene really exists. The next important study was on the CTRC. This is actually G was from a German cohort, and there was a replication cohort from a few Indian patients, a very small number, 71 patients and 81 controls. And in this also, the C217 SNP was giving a highly significant odds of association with chronic pancreatitis. But again, in idiopathic, we don't call TCP now, it's a historical term, I would say. But again, because of the numbers, we should be a little careful in interpreting this result in the Indian cohort. The third study, again from Dr. Garg's group, who had elegantly shown the SPINK and CFTR gene mutations were associated with idiopathic chronic pancreatitis, not the so-called tropical. And that was followed by another study. Again, G was on a German cohort on non-alcoholic CP, and again, there was a validation cohort involving Indian patients, and 230 patients, a decent number, 264 controls. Again, this particular mutation was shown to be strongly associated with early onset chronic pancreatitis. Dr. Whitcomb had published his GWAS on claudin, I think in 2012, and we followed that. That was mainly in patients with increased susceptibility in alcoholic chronic pancreatitis. Then we tried to see this in other patients, non-alcoholic idiopathic chronic pancreatitis, idiopathic recurrent, and we could show that claudin, few of the polymorphisms were also increasing the susceptibility to non-alcoholic or idiopathic chronic pancreatitis and recurrent acute pancreatitis. And that was followed by a very good GWAS by the INDIPAIN. Dr. Garg was one of the principal investigators. Again, in that same study, a large cohort of patients actually had shown that all these SNPs in the PRSS, claudin, and the MORC-C4 genes were strongly associated with idiopathic chronic pancreatitis and alcoholic chronic pancreatitis. And that was followed by a study from CCMB in Hyderabad, again led by Dr. Chandak. Again, they could show the similar results with a high susceptibility risk in the presence of claudin MORC4 polymorphisms, and PRSS1 and PRSS2 actually had conferred a protective benefit. And this is the most recent. We had seen this earlier. Sudipta and Dr. Sandhya had published this, and I think they'll be coming with more larger studies to show the strong association with Indian patients. So So what we do in our center is, I mean, based on all the polymorphisms that had been presented or published so far, these are the few which have shown strong association. And if we look at this data, so these are the polymorphisms that are strongly associated with Indian patients with chronic pancreatitis and recurrent pancreatitis. SPINK has the strongest predilection. But if we see PRSS, cathepsin B claudin, these are also common variants found in the general population. Still, they have some susceptibility, but with a low effect size. The odds ratio are not as good as SPINK. And this is something that we are looking at currently. So this is the map of India and the proportion of patients sample that we have from across the country, including the neighboring countries like Bangladesh and Nepal. So far we have 1,280 patients, and controls, actually we are building up the controls. The data I'm showing in the next two slides is just based on 500 patients, but we are planning to have more controls over the next couple of months. The median and the mean age, all young patients, 22 years and 27 in the controls, majority males. So here we are trying to look at the combination of genes. So we had talked about the individual genes, the individual susceptibility, but so a patient may have different polymorphism. So what about that? Is that giving an extra additional susceptibility factor? So in the whole cohort, around 9% of patients at all wild type. So majority had some kind of polymorphisms in this patient. At least one SNP was seen in 32% of patients, and all of the others have a different combination. In fact, there were a total of 84 combinations of different homozygous, heterozygous variants, and here this is the top 30. So if we see here the combination of cathepsin B heterozygous with PRSS1 heterozygous, this is the intronic variant, not the R122H HP variant that is found in the West, and SPINK heterozygous. So this has a high odds ratio of almost 4. If we look at this combination, CTRC heterozygous, cathepsin B heterozygous, SPINK heterozygous, again a very, very high odds ratio of 10. PRSS1 heterozygous, SPINK heterozygous, again almost 3. CTRC heterozygous, PRSS heterozygous, SPINK 1, almost 7-fold increased risk of recurrent acute pancreatitis. And most of these patients in this cohort were actually recurrent acute pancreatitis. Small group had early chronic pancreatitis, early changes on EUS or early ductal changes in MRCP. And if we see these odds ratio are significantly higher than the risk conferred by the single genotype, except for SPINK1 homozygous. So this means that this combination is having some kind of gene-gene interaction at the functional level. We don't know, we might have to evaluate further. So we went one step ahead and tried to look at the age, separate the cohort by age group. So we looked at a pediatric patient less than 18 years and young adults beyond 18 years. And again, there were a whole lot of combination, but out of that, this 3 combination turned out to be giving the highest risk. So the combination of CTRC heterozygous, cathepsin B heterozygous, SPINK homozygous, this was highly favoring recurrent acute pancreatitis in the pediatric population. Similarly, CTRC SPINK homozygous again was highly leaning towards the pediatric population. On the other hand, cathepsin B heterozygous, CTRC heterozygous, breast heterozygous was leaning more towards the young adult. So this shows that this interaction between the SPINK as possibly the central player and its combination with the other factors would lead to increased disease onset during childhood, and these are the patients who are likely to be progressing to chronic pancreatitis over time. And this understanding is important because this would help in genetic counseling. Usually there is lots of debate, should we do a genetic testing, because I'm sure half of the audience here would be skeptical about doing a genetic testing in these patients, but if we know the susceptibility risk, the combination of genes, then that would be important factor for counseling, and I think we'll hear that more in the next talk. And this gene-gene interaction has actually been shown in several studies from the West. For example, if we see Heterozygote in SPINK1 and CFTR could increase 64 the risk of chronic pancreatitis. Second compound, heterozygote of CFTR, SPINK1, the common variant, again has a significantly high risk of pancreatitis. Synergistic effect by combination of CFTR, SPINK, CFTR, CTRC, additive multiplicative effect. Again, TRPV6 with CFTR can have an additive effect. So the gene-gene interaction is very important in assessing these patients. Now, if we look at the GWAS study, again, if we see here, if we go deeper into the study, the patient who carried the N34S SPINK was significantly younger compared to the patients who had the PRSS1-2 risk genotype. But the patients who carried both this genotype had the disease onset much younger. Again, emphasizing the importance of SPINK as one of the key drivers of our patients with recurrent acute chronic pancreatitis. And if this risk allele was present from the claudin with SPINK1, then there is a delay in the onset of the disease. Further, if we look at the GWAS from Dr. Garg and his group, as there was an increase in the genotypes or polymorphisms, the odds ratio of developing the disease was higher. Again, that could probably be talking about or dealing with some gene-gene interaction. So if we look at this, again, all of you know this, as the allele frequency is low, it's rare, the susceptibility or effectitis would go higher. For example, the PRSS1, especially R122H, which is the hereditary pancreatitis gene. So in India, we usually see these genes and SPINK and CTRC. So CTRC is known to be causing trypsin activation. SPINK is a disease modifier. And these genes are more common in the population and have a low effect size. So probably this combination of this high susceptibility and more common gene could increase the risk of the disease in this patient. Now, what about gene-environment interaction? We always talk about gene, but environmental factors like alcohol, smoking, morphological anomalies like pancreas divisum. So are these also interacting with the genetic polymorphisms? And there are actually studies which have shown that a patient who has alcohol and has a SPINK mutation or a few other polymorphisms has an increased risk of. And in fact, now alcoholic chronic pancreatitis is not considered as a disease of alcohol. Probably alcohol is a bystander or probably just a additive factor. What about pancreas divisum? Again, this is a very early study and probably the first study that have shown from Dr. Garg's group. There is an association of SPINK and CFTR polymorphisms with pancreas divisum. And then when we looked at this a little bit more detail, where we studied around 722 patients, individuals, 244 controls, 176 IRAP, 276 ICP. So what came out was the patients who had the cathepsin B polymorphism with pancreas divisum, especially the patients with idiopathic recurrent acute pancreatitis, they had almost a 4-fold higher risk of recurrent acute pancreatitis. So here it can be debated, because this is a gene-environmental interaction, so we cannot change the gene. So if we change the environment by doing a sphincterotomy, that's a wishful thinking, or I'm thinking aloud, would that reduce the risk of recurrent pancreatitis? Probably the SHARP trial, if they do some more subgroup analysis, could answer this question. And the other important thing, this is something very new. Till few years back, we thought the HP genes, especially the R122H and 29I, are not seen in our Indian patients. But recently we had come across 2 patients who had both of these positive. And this is possible likely because of mixed marriages like transatlantic travel and settling abroad, coming back. So this means that if we find 1 or 2 cases, we could find more cases in the future, and we could also find homozygous. And that is where the risk of hereditary pancreatitis will increase. So it's important to look for, again, these mutations in our patients, especially young patients with recurrent acute pancreatitis. And that also forms a case for genetic testing in very high susceptibility population. Not everyone, very highly susceptible population. So I think I'd stop here with these takeaways. So SPINK1 still has a major driver of genetic-related pancreatitis in India. HP-related PRSS genes likely to come up more in the coming years because of travels and mixed marriages. We need to study more CP and CTRs in the Indian patients. Claudin, cathepsin B are common variants and may add on to the pathogenesis with low-dose effect. More gene-gene interaction and functional studies need to be done. And I think, again, this is a great thing Sudipta and Dr. Sandhya has come out with this first paper to look at the genomic map in Indian patients, and I think more data would come in the near future. And finally, there has been, genetic testing is important, but there has been a trend of going for exome sequencing for clinical diagnosis. I think exome sequencing should be restricted to research at this point, and only targeted mutation has to be done for testing in the clinical scenario, because this is what happens. We do exome, we get many things. And many times we don't know what to do. The patient gets worried, the physicians get worried, and then things gets more worse than better. So I think I'll stop here and I'd be happy to take questions. Thank you very much.